Hello, everybody. Welcome to episode 5 as we continue our conversations around what folks need to know in various aspects of the world that I circulate in here in the Department of Medicine at Mount Sinai Beth Israel. And joining us today to help further that conversation as we look at some of the exciting ongoing things happening in endocrine and in diabetes in particular, is Dr. Zijian Chen, who's an assistant professor of medicine here at School of Medicine, has a number of administrative roles, including the medical director of our ambulatory subspecialty practices, of the endocrine practice in particular, and of our post-COVID center, and probably 6 other things. And in those roles I feel like every time I turn around, I see you on TV or in an article or something. So thank you for peeling away from some of those things to spend some time with us. I really appreciate it.
Thank you for having me.
So, I feel like diabetes at this moment is such like a dynamic disease state and subspecialty. I feel like there are so many things changing that I, as a primary care doctor, and that patients need to know. In particular, I'm thinking about some of the new medicines that have entered the market over the last couple of years. I'm thinking about like the SGLT2s and the GLP-1s. Can you just sort of update me on what's the stuff that I need to know about that?
So you're right. There are many changes happening over the last few years in regards to diabetes management, centered around medications. And the two really big classes of drugs that are the newest in our armament for treatment of diabetes is the GLP-1s and the SGLT2s. And they are very exciting medications that we, are able to use for our patients. So to start, the GLP-1s, this is a class of medications that helps control the patient's blood glucose by simultaneously reducing hunger as well as causing the patient to make more insulin when they eat. And what this does is it gives a dual effect of having to help the patients with their weight, which is one of the main causes of diabetes and worsening diabetes, as well as helping with the high glucose that these patients have when they eat. The added benefit as these drugs evolve is that, the earlier form of these medications were daily or weekly injections. And while those injections are still available now, there's actually oral formulations that are coming to market.
Great. And can you remind me like the names of some of those, just in case people have heard them
on
the ads or tossed around?
Of course. So most commonly what they would hear are the older medications such as Bydureon and Trulicity and Victoza. But the more, I think, recent formulations are something like Ozempic or Rybelsus.
And when picking, if I'm a doctor who's picking among those different choices, like is some of that driven by the insurance companies, like who covers what, or are there real kind of nuances that I should be thinking about among those differences?
There's certainly nuances, meaning there's some classes that are better for weight loss. There are some that are more cost effective. There are some that are easy to administer. So those we take into account when we choose the medications. The newer medications, such as Ozempic, the weight loss effect is actually much superior compared to the older medications. And in addition to that, the older medications are now available in higher dosage forms, which can also have benefits of even more hunger reduction as well as glucose control.
That's great. And my patients who are on these, they're thrilled by the weight loss aspect of it, no question. So what about the SGLT2s? What do we need to know about those?
Yeah, so the SGLT2 is the new kid on the block, as or as I like to call it for some patients. It is the newest form of medication that we have for glucose control. The way it works is it causes the patient's kidneys to urinate the excess sugars that they have in their body. And one of the fears that we see in patients is they're thinking, well, if I'm urinating more sugar, am I hurting my kidneys? But that's not the case. In addition to helping with the sugar control, there are many studies now that shows that there is also benefit to the heart and the kidneys over the long term. So this is really a medication that's really great at controlling the sugar as well as helping with the comorbid conditions that you can have with diabetes.
Right. And certainly, the first time I saw this, it did make me nervous when somebody had all this urine, all this sugar in their urine, and clearly it was because of their medicine. But it's shocking the first time you see that it's really working, that the sugar is all coming out.
Yeah. I mean, we use it with caution, of course, as with all medications. I personally warn my patient of several things with this medication. Number one, dehydration. It's
Mhm.
very, very common that can happen. And I recommend the patients to drink more water as much or until their urine is clear, because that's a
Mhm.
really good way to see whether or not your body is concentrating your urine.
Yeah, no, I think that's a good point. And there were some other safety concerns, I think, around like yeast infections and stuff like that. I mean, how, for medicine that's only been on the market a few years, like how worried do I need to be about some of those things?
Um, I mean, there is a risk. There's absolutely a risk. Yeast infections and urinary tract infections are actually common in these patients. By common, I mean anywhere from 5 to 10% of patients taking these medications can have yeast or urinary tract infections. That's why we also warn patients of the side effect. And when they notice that, let's say they have pain with urination or sometimes even blood with urination, that they let us know and that we treat this adequately. And as long as the patient, I think, understands the risks of taking the medications, they would actually have great benefit with it.
Right. And so safety is key. Clearly, they're effective. What about the cost? Because I feel like every time I try to prescribe these, I'm working with the insurance companies or the copays or something to try to figure out how to get them covered.
Yeah. I mean, cost is always a problem, especially with new medications. And it's about, the cost of development and all of those things, which I won't go into. And I'm sure, that you understand. But there are also ways to get the medications for the patients. These drugs are now recommended in the pathway for treating diabetes from the American Diabetes Association. So they are second line agents, and because of that, they are actually well covered with most insurances. Because most insurances do offer at least one, if not more than one of these medications on their formulary. The copay can be a tiny bit high for these medications, but the drug companies themselves, they actually offer discounts for the patients going through their programs. So there are often vouchers for free samples and also copay cards that we can use to subsidize a part of the cost.
Got it. And then, we were talking about the new medicines, but even I feel like insulin, which has been around for decades, it seems like it's getting more and more expensive. I mean, I don't know. I feel like I have people constantly like switching insulin brands or having trouble if they're paying cash. What's your experience been like with that?
So the cost of insulin is expensive, and it's not just the administration of insulin, meaning getting the insulin itself, but also there are supplies that's associated with taking the insulin. So the added cost of everything together can be quite daunting for some patients. Um, in my view, though, I think it's actually getting to be a little bit cheaper, and the reason I say that is because there's more competition.
Hmm.
If you look in the past, in the late 90s and early 2000s, you had essentially two or three companies making all of the insulin that was available on the market. That has changed. These companies now produce generic forms of their branded insulin.
Hmm.
And this is in response to many other brands and companies making their own insulin that are analogs to the ones already on the market. So this competition is giving consumers, meaning the patients, a better access to these insulins.
Got it. So we've talked a little bit about some of the new drugs. We talked about insulins. One of the reasons I love talking to endocrinologists is hearing all the like tips and tricks that they like to share with patients about even the medicines that have been around for ages. Are there certain things that you tell people when you start them on metformin or whatever to give them a little bit of guidance about what the best, the best versions or the best ways to take them?
Yeah, I think one of the things that, because of the amount of time we're able to spend with patients, which is always not enough, there are, I think, quick tricks that we should use in order to give the patients the most benefit out of using any medication. So for metformin, for instance, one of the biggest complaints we have from patients is that they get gastrointestinal side effects and they swear the drug off forever.
Mm,
And one of the first things I tell them is you got to take it with food, and you always have to start at a low dose. And that's the approach I take with every patient on metformin. And
and do you feel strongly between the extended release and the immediate release?
I think that for some patients, they do have persistent gastrointestinal side effects, even if they take it
Regardless.
correctly. And that's when the extended release really does help. But in other cases, it's just, they were started incorrectly and they were started and not taking it at the right time. And that is the cause of the side effect.
Got it. And what about other things? Sulfonylureas, I feel like.
So sulfonylureas have fallen somewhat out of favor for the
Yeah.
use for diabetes treatment. I mean, there was something that in the past was one of the few medications that we had and only medications that we had, and we used them very commonly. However, for patients now, there's just better options out there. And sulfonylureas do come with a risk, the biggest of which are hypoglycemia, meaning having patients taking sulfonylureas and experiencing very low sugars. The other risk is that you can have weight gain, which of course is not good for diabetes. And there's some studies that shows that using sulfonylureas versus other medications, the patients actually start needing insulin quicker while on
Right.
sulfonylureas.
Got it. And then I think we talked about injectables a little bit, and I think you've had some experience thinking about like pills versus injectables.
Yeah.
Tell me about that.
Yep. So diabetes is a very special illness where it's one of the few illnesses where you have to inject yourself to treat yourself. And I like to keep that in mind because it is very different from something like high blood pressure or high cholesterol. In regards to injectables, it's always very difficult to start patients on it. In fact, I actually take placebo, needles and stick myself because I want to know how and what my patient goes through when I treat them. And it allows me to explain to them, number one, the sensation of the needle and how it feels, but also for me to understand what I'm putting them through when I prescribe something.
And what did you learn from that?
Well, what I find that number one, the needles that we use are very painless. They're very, very tiny.
Nice.
They are about, I would say, I don't know. It feels like a mosquito sting, which is unpleasant to some people, but actually not terrible. And it allows me to connect with the patient and let them know that, I have experienced this, it's not that bad. And yes, it's something different. And it's not a pill, it is an injection. But in the end, this can really go a long way to treating you and making your diabetes better.
Yeah. I mean, and so injecting with needles is a big piece of that. And also, I guess, checking your blood sugar all the time probably hurts even more, I figure.
Yeah.
And I mean, now there's new technology, for CGMs and stuff to try to figure out how to avoid needle sticks. How does that work?
Yeah. So one of the other great advances that we had, I think, with the computer age, if anything, is these continuous glucose monitors or CGMs.
Yeah.
So in the past, they were very expensive. Insurances will only pay for it for type 1 diabetics and not type 2 diabetics. But this has changed. I mean, there are cheaper options on the market right now. There are multiple options. And with competition, of course, the price becomes better. And these are great tools. It allows a patient to know whenever, wherever, what their sugar is, and with minimal effort and no multiple needle pricks. So it gives them a chance to really learn about their diabetes because they can see the progression of their glucose from meal to meal or from one type of meal to another type of meal.
Right. And so just remind me how that works practically, right? You hook it up on your arm or wherever. And does insurance pay for it, or people pay for it? How much does something like that cost for somebody?
Yeah, so the device itself, depending on the device you pick, is probably the thickness of, I would say, 2/4. And then the size is about maybe 1 to 1.5 quarters next to each other.
Hmm.
It is inserted with a needle, but what happens is after the insertion, the needle comes out, and the only thing that remains under the skin is a plastic catheter. And all it does is it measures your glucose in your interstitial fluid, meaning the fluid between the cells, and it measures it every few minutes. So the patient will have a device that gets all of the readings so that they can look at what their sugar is at all times. And in regards to costs, out of pocket, uh, one of these devices, the cheaper one, would cost about anywhere from $50 to $75 for every 2 weeks,
Hmm.
and that's without insurance. With insurance, you can get it for anywhere from like a $10 to $25 copay per month.
Wow. And so which patients are you recommending that for now? I mean, it sounds like a great tool.
I think it should be used for all patients, because if we look at the other ways we evaluate a patient's glucose, from your A1C, that's every 3 months, to your finger stick glucose that the patient does by themselves, this is a much better tool. And it's a great tool not only because it gives us what the sugar looks like, but it also teaches the patient. You can tell the patient, look at this meal that you're eating, and then look at what happens to your sugar afterwards. And they themselves can start learning, what's a good meal, what makes
Hmm.
my sugar rise a little bit versus a lot. And that's a way for them to learn over time how to treat their own diabetes.
And do you as a doctor feel overburdened by all these data now? Because instead of getting like, a couple of readings on a piece of paper and, a hemoglobin A1C from the lab every 3 months, I mean, now you're getting, every 6-minute blood glucose readings or whatever. How do you work with that?
Well, I mean, the data can be overwhelming, but that's why, we spend time to learn how to use these tools. And I think it actually is very useful in some ways, and actually, if anything, better in some ways. For instance, having a glucose monitor, a CGM, when the patient comes in, we download the data and it's a complete set of data as long as they wear it.
Right.
Whereas the finger stick, if they are sporadic about checking, you can have a lot of missing data. And because of that, we give subpar care.
Hmm.
And don't even get me started on A1Cs. I mean, an average reading every 3 months, I mean, it gives a really nice, broad picture of what the patient is doing, but there's a lot of deficiencies with using one test to tell how a patient is doing over 3 months.
Right. Somebody could be too high half the time and too low half the time, and their average looks perfect.
Exactly.
Got it. All right. So what about pre-diabetes? I mean, when people come in and they're getting their speaking about A1Cs, they get their A1C checked, or somebody did a finger stick or a blood glucose or something that was high. What should we do with folks in that boat?
So I think education is really important. I can't stress this enough for all patients with diabetes or pre-diabetes, because diabetes is a spectrum disease, meaning it doesn't go from one moment you don't have diabetes to the next moment you have diabetes. It doesn't develop all of a sudden. It is a accumulation of all the bad habits and weight gain and high glucose that you have over the course of many years. So when someone is pre-diabetic, it means that they've been already having intolerance to glucose for, I would say, at least 2, 3, if not longer, number of years. And it's time for the patient to learn about how to actually reduce their glucose burden so that they can reverse the course of pre-diabetes turning into diabetes.
And so what's the best way to do that?
It's actually something that is easy to say and hard to do, which is diet and exercise. I think reduction in glucose burden, meaning eating less food that has starches or simple sweets, that will already reduce the amount of glucose the patient takes in, which will slow down the course of diabetes and turn it around. And exercise also helps, and the reason it helps is because it sensitizes the tissues to be able to take in glucose easier. And if patients are able to make this intervention earlier, they may not even need medications.
Right. Because, I mean, because it's so hard to do, easy to say and hard to do, I mean, people do come to me looking for medicines for their pre-diabetes. I mean, a lot of the things we've talked about today are medicines that people can take even if they don't have full-blown diabetes. How do you decide who's a good fit for medicine and who should really kind of double down on the diet and exercise advice?
I think everybody should double down, but
Okay.
but when the patient is willing to try taking medications to kind of reverse the course of the pre-diabetes, I think anyone who is willing should be able to go on it. The reason being, what I would use would first line be metformin because it's a sensitizer to for the body for insulin,
Mhm.
and it does really bring glucose values down, especially in pre-diabetes. And what it also does is it is slightly weight negative, so at least it'll prevent the patient from gaining more weight and maybe even help them lose weight. And then finally, the side effect profile is very well tolerated. It is really a harmless medication unless the patient develops severe gastrointestinal side effects.
Got it. So diet and exercise for everybody, and medication maybe to try to help move that along. Excellent. Those sound like good parting words. Thank you, Dr. Chen, for joining us today. I really appreciate it. And thank you, everybody, for joining us. See you next time.